There we go. All right, so we'll get started now. Welcome to the Surgical Informatics lecture series. This is an approximately monthly series in which we have experts from the informatics world teach our lab about important concepts and how they can be applied to research in surgery, and where we also discuss innovative and new studies from these fields. Just for a bit of background, my name is Jayson Marwaha. I'm a general surgery resident and a postdoc in the Surgical Informatics Lab, which is a lab based jointly at the Beth Deaconess Medical Center Department of Surgery and the Harvard Medical School Department of Biomedical Informatics in Boston. The lab is run by Dr. Gabriel Brat, who's a trauma surgeon, intensivist, and informaticist at these two institutions as well, BIDMC and the Harvard Medical School. And our lab studies topics related to informatics, data science, and surgery, of course, from intraoperative computer vision work to building and deploying surgical prediction models and many, many other things. And so for today's lecture, I'm excited to introduce Dr. Tyler Loftus, who is an acute care surgeon and an assistant professor at the University of Florida Department of Surgery, and has written extensively on surgical artificial intelligence for decision support. And in particular, today we'll be discussing a recent study of his published in JAMA Network Open last month entitled Performance of a Machine Learning Algorithm Using Electronic Health Record Data to Predict Postoperative Complications and Report on a Mobile Platform. And we chose to discuss the study today because it is very closely aligned with a lot of the work we're doing in our lab to sort of make machine learning a valuable part of a surgeon's routine clinical activities. And so I think that all of us in the lab have a lot to learn from this work. So with that, Dr. Loftus, thank you very much for joining the lab today.
Yeah, thank you so much for having me. I appreciate that introduction.
And so what I'll do is, typically what we do is we have someone from the lab sort of summarize the paper for everyone. In that case, today it'll be me. And once I sort of spend the next 10-15 minutes or so going through the paper, then Dr. Loftus, if there's anything in particular you'd like to highlight, interesting findings, or anything like that, then you are welcome to do that as well. Oh, there we go. And so we'll spend 5-10 minutes doing that, and then we will open it up for questions and discussion from everyone in the lab. So why don't I go ahead and get started? There we go. So again, this is the paper that we'll be discussing again. It's performance of a machine learning algorithm using electronic health record data to predict postoperative complications and report on a mobile platform. And it was published last month in JAMA Network Open. And sort of in true JAMA manuscript format style, I'll be sort of kind of giving the key points first. So the sort of like 10,000-foot view of what the objective and findings and meaning is of the study that they conducted, and then we'll go into some of the specific details. So the specific question or objective rather that they wanted to address was building a artificial intelligence platform that can predict postoperative complications. But the keys here are that they wanted to use automated real-time EHR data and present the model output on a mobile device. And so, I think that for our lab in particular, and I think for us, everyone in the audience who's sort of interested in surgical informatics, the keywords here that pique our interest are real-time and mobile device. And the reason why I think is because, we're all sort of familiar with the many clinical risk prediction models that are published in surgical journals every year. But the sort of quandary seems to be that not very many of them, if any at all, are regularly used in routine clinical practice by surgeons. Surgeons very rarely consult the many available published risk prediction models to guide their clinical decisions. And so one potential reason I think that might be a barrier to them using it more regularly is the fact that many of them aren't able to deliver predictions using real-time data and sort of deliver it at the point of care when the surgeon needs the prediction most. And so we sort of were interested in this paper because we thought that maybe one sort of approach to sort of cracking this code of making these types of tools useful to surgeons at the point of care is to use real-time EHR data and deliver it on a convenient platform like a mobile device.
Yeah, Jason, I'm glad you captured those key points. I would add that actually for us, the automated portion was another important part, because I think, as you mentioned, one of the major barriers is actually getting these models to clinical implementation. And one of the things that we've come to know, as everyone has, is that you really have to lower the activation energy for the clinician to get them to use something. Any kind of manual data entry requirements make it less attractive for kind of clinical use, especially on the run under time constraints. And so another aspect of this was to try to automate that pipeline, so it pulls everything from the EHR and then auto-populates the algorithm and goes straight to the outputs without having to enter anything. I think that the Potter app is a great example of something you can get on a mobile device, and you have to enter very, very few parameters, often just 4 to 6 or maybe 8 parameters. This was an attempt to try to see if we could do it entirely automated without having to enter anything.
Yeah, and I think that's a really important point as well. Thank you for bringing that up. You sort of and I agree with that perspective. I think sort of in the era of, or in the way we traditionally think about risk calculators, where you log on to something like MD Calc and you put in, maybe 5 or so parameters, that's sort of a realistic expectation. That's a somewhat realistic expectation and is somewhat manageable by the end user who's seeking a prediction. But when you then take a step towards more complex models, like machine learning models that have hundreds, if not more, inputs, then it all of a sudden it's no longer practical to expect the end user to manually sort of look up the creatinine and look up all these other input features and manually put them in order to get a prediction. So I think that automated retrieval of the entire feature set is also a barrier to use for many tools, and I think another very clear value proposition for the tool that you built in this study.
Yeah, that's a great point. There are some very parsimonious models that achieve high performance. We're not able to achieve very high performance with just a smaller set of predictor variables. It might just be a model architecture thing, but for us, we found that we improved model performance by enriching it with all these features, as you show there, 135. And so that was the thought with automating them, that if you can have a parsimonious model like Potter or like Surpass, for example, then it's realistic to enter them manually. For us, it wasn't. And so that's why in this case, we automated the pipeline. But you bring up a great point that for a parsimonious model, realistic to expect a clinician to enter 4 or 5 variables.
So continue on the sort of 10,000-foot view. So the data that they used to build the model in the study was about 74,000 inpatient surgical procedures from the University of Florida. They sort of developed a number of models and found that a random forest model with 135 input features had approximately the same predictive performance as surgeons themselves in predicting the likelihood of a patient developing any particular postoperative complication, and developed a mobile application where the output for any given patient was not only the prediction, being the likelihood of any given postoperative complication, but also the top 3 predictors of those complications as well. And so what sort of does this study mean? Well, and I think briefly in a sentence, it shows that there are ways to deliver timely and accurate predictions that rely on automated retrieval of EHR data to input all features and thereby integrate predictions about post-surgical complications into the clinical workflows of surgeons. And so to delve a little bit more into the details of the study, just for a bit of background, so we sort of have touched on this already, but one of the big sort of proposed barriers to using AI decision support tools routinely in surgical care is that in many cases, they require the input of a lot of several pieces of data, and that can be time consuming, and it's not practical to rely on the surgeon to put in several pieces of data in order to get the prediction that they want. And then the other sort of issue is more broadly the idea of integrating these types of tools into the clinical workflow of the surgeon. It's if they're not easily accessible at the point of care, then the likelihood that that they are going to be used is somewhat lower. And so, as an effort to sort of address some of these barriers, the authors focused on one particular previously retrospectively validated model, which is called My Surgery Risk as sort of a use case, and focused on that to try to build something that can be used more easily by surgeons at the point of care. And so a little bit of details on My Surgery Risk. I'll in a second show the original paper that reports its development, but it essentially is a surgical risk prediction model that predicts the likelihood of any given patient developing a set of postoperative complications using EHR data. And so it was sort of developed and retrospectively validated in a prior study. And the goal of this study was to prospectively validate it using prospective data at the University of Florida, and then also make it accessible on a mobile app and use automated EHR data entry to generate predictions. And so this is the original study where My Surgery Risk was developed. It was published in Annals of Surgery last year. And you can see here that it predicts the likelihood of this set of major postoperative complications as well as postoperative mortality. And in fact, actually, what the paper reports is not just one single model, but the performance of several models, which I'll go into in a bit more detail in a second. But essentially, there were sort of 6 different types of models with 6 different feature sets and 6 different algorithms that they used to predict postoperative complications. And so that's sort of a bit of background on My Surgery Risk and the barriers to use of these types of tools in clinical workflows that the authors intended to address. For a bit of background more on My Surgery Risk, the data that it uses, and Dr. Loftus, feel free to speak more to this if there's additional detail you think is worth noting. But essentially, it takes in EHR data from a patient's 1-year medical history prior to surgery, and so that includes things that you'd typically expect this type of model to include, and things that can be easily retrievable from the EHR, like medications, lab results, comorbidities, as well as sociodemographic data by linking the data set that they had with Social Security Death Index and some other sort of external data sources as well. And so that data could be used in the sort of preoperative phase to predict the complications and mortality that were specified in the Annals of Surgery paper.
So Jayson, I would like to add that regarding the sociodemographic data, I believe that when this model started training, we were only using 5-digit zip codes, which was sort of crude, I think, for representing sociodemographics. And we did pull, sort of socioeconomic profiles from zip codes. We've moved away from that, as I believe you have, towards area deprivation indices and 9-digit zip codes to have a little bit more granularity down to sort of the city block level. And so that's probably an opportunity to improve and enrich these models. But this started training a long time ago, and I believe it was just 5-digit zip codes. So that's a weakness there.
Okay. And now,
can I ask
okay.
can I ask a question actually really quick?
Yeah, please do.
And so this is partially because I'm not a surgeon, but I was curious, what types of differences would there be in the decisions a surgeon would make if they had this information compared to if they didn't?
Yeah, no, that's a great question. So it depends a bit on the phase of care when they're presented with this information. And we are doing usability studies now to try to better answer your question, which I think is a very important one. In the preoperative setting, before you have the intraoperative vital signs and the surgical summary, that could be when you're meeting a patient in the emergency department, like Dr. Brat or I would be as trauma and acute care surgeons, or if you're meeting them in clinic to schedule an elective case. And we're trying to give the patient some sense of what is your risk for complications, what is the probability that you make it out of the hospital alive, let alone that you have maybe a prolonged ICU stay, develop an acute kidney injury that's associated with long-term morbidity and mortality, complications like that. And it's a bank of 9 different complications. So it's a way to give sort of objective prognostic information, and identifying the top 3 risk factors is potentially a mechanism by which you could identify risk factors that might be amenable to mitigation. So let's say you have high risk for acute kidney injury and the top risk factor is nephrotoxic medications. Well, hopefully we would all stop nephrotoxic medications for someone at high risk for acute kidney injury in the preoperative setting. But it is a process that automates that and identifies that to make sure that things like that don't slip through the cracks. And then the other decision-making point is probably right after surgery, after the model's been enriched by the intraoperative data, the intraoperative vital signs, the surgical summary, what surgery was actually done. Realistically, the model would only have the planned surgery, not what's actually billed in the end, because we don't have that information at surgery end time. But one possible application there in terms of decision-making, to go back to your question, is, and this is an interest of mine, is should this patient be admitted to an intensive care unit? Or is the risk for complications so high that they should be very closely monitored and surveilled in an environment where there's each nurse has only 1 or 2 patients, and there's a bunch of critical care trained providers around to rescue that patient if they develop a complication, also be highly vigilant to see complications coming and try to prevent them before they happen, versus can they go to a hospital floor where you have less frequent monitoring? A nurse has often 4 or 5 patients, and the doctor is usually around on that patient maybe twice a day. And then also if they hear that there's an issue, much lower frequency surveillance. And so aligning the patient's risk for complications with their postoperative triage destination, like the ICU or the floor, or can they even be discharged home, would be another decision-making point. And we think that the prediction of risk could be something that could contribute to that decision, which surgeons already make, but in this case, you could anchor that decision with some objective, data-driven predictive analytics.
I see. And so it sounds like rather than supporting one specific decision, it sounds like there's multiple different almost use cases depending on what the nature of the operation is, what the nature of the clinical scenario is. Is that right?
That's correct, yes. And I tend to focus just on the triage decision, is sort of where I'm kind of branching up into kind of one discrete decision-making scenario. But you're right, I mean, risk assessments can be applied globally to risk mitigation, which is very broad, and then also just the prognostic information for the patient to give them, instead of just saying you're high risk, you're likely not to do well, you have high risk for death. This would put a number on it, and that may help the patients rather than the surgeon kind of make decisions about whether to undergo surgery and how this might affect their life. But yes, this as it's presented in this paper is very broad.
I see. Okay, thank you.
All right, so continue on. So to continue just on sort of the methods for the study, as I mentioned earlier, the inclusion criteria for people in both the retrospective and prospective cohorts were patients undergoing inpatient surgical procedures at the University of Florida. The retrospective cohort that was used to develop the model was from cases from 2014 to 2018. included about 42,000 patients. And the prospective validation cohort that was used to prospectively validate the model in this study had about 20,000 patients and was the study period for that was 2018 to 2020. So once they had their cohorts, of course, the next task was data harmonization, because you have data from disparate sources and many different types of data that you need to convert to a sort of standard data model from its native model in the EHR. And so all the inputs that were needed for the model were converted to some common data standard, whether it be LOINC for lab values or the OMOP common data model or RX norm for drugs as examples. Then were used as inputs to the model. And one advantage here that I'd sort of note is that, if you design a model in this way where you can have the inputs be things that are standardized as far as data models go, then I think one advantage there is that you have opened up the possibility for the model to be deployed in a number of different settings, and you've suddenly increased the versatility of the model, because while each native EHR data standard may be a little bit different, if you sort of simplify it to inputs as being LOINC codes, RX norm codes, et cetera, then the possibility of expanding to, say, other institutions, I think is much greater. So once data was harmonized and ready to be used as inputs, then the individual algorithms were prospectively validated. As I mentioned, there were actually 6 MySurgery risk models that had been developed in the original paper. 3 were generalized additive models and 3 were random forests. And each type of model took either a 55 input feature set or 101 features or 135 features. So, each of the 3 random forests as examples, one random forest had 55 inputs, one had 101 inputs, one had 135 inputs, and same for the generalized additive models. And then the performance of each was compared against one another. So from a high level, this is sort of what the sort of MySurgery risk sort of system sort of looked like. So we discussed briefly the sort of types of data that go into the model. And important to note here is that once data was retrieved from all these different sources, it had to be sort of standardized into a sort of common data model. And then a sort of standard data exchange system had to be used as well, so that the models both inputs and outputs could be retrieved and outputs could be displayed to the provider. Another interesting point here is that given that there are multiple data sites within the University of Florida, they also relied on this data exchange standard to be able to get data from both sites. Is there anything in particular, Dr. Loftus, here that you think is also worth noting in this sort of high-level overview of how the entire analytics platform worked?
No, I think that was a great summary.
Okay. And then, so I think very sort of the next step was to develop the app itself. And so here's just sort of what the mobile application looks like. So the surgeon can sort of see the cases, the patients that they'll be operating on for that day or for any given day. And say, they select one of the patients, they can see the patient's sort of objective medical data, like their comorbidities, labs, et cetera. Now, notably, for the purposes of the study, before it showed a model prediction, it first asked them for their preoperative assessment of the patient's risk of each of the complications that MySurgery risk predicts. So AKI, prolonged ICU stay, et cetera. So this is sort of the surgeon's assessment of the patient's risk. Once they had rated the patient's risk for each individual complication, then the model displayed its prediction of the patient's likelihood of every given complication and this for each complication displayed the top 3 predictors, or the top 3 most important predictors. And of course, of note here, you'll notice that there is no sort of page for data entry, because the sort of model prediction can be automatically generated by retrieving data from the EHR without depending on the surgeon to input any sort of new information. Oh, and then another important point to note here is that for the purposes of the study, in many of the cases, after the surgeon saw the model's prediction, they then were asked once again to rank the patient's or rate the patient's risk of every complication again to see how my surgery risks model predictions influenced their perception of the patient's risk. Also interesting to note here is that in addition to displaying a point estimate for a patient's risk of any given postoperative complication, the My Surgery Risk mobile app also showed patients with similar risk profiles for that surgeon. And you could select any given patient with a similar risk profile to the patient you're just about to operate on and see what their risk profile looks like and how it compares to your patient's risk profile. And finally, it gives you the opportunity to look at sort of service level metrics and departmental level metrics as well, as far as complications goes, which may be both of interest and useful to the surgeon who's evaluating the patient sitting in front of them. So that's what the application looked like. Now to sort of go into detail about some of the numbers. So this is what the patient characteristics looks like for the development cohort and the validation cohort. And I think the one element of this large table to focus on is the differences in complication frequency between the different cohorts. They were largely similar with the exception of some complications. So for example, for neurologic complications, the development cohort had somewhat of a lower the development cohort had somewhat of a lower complication rate as far as neurologic complications went than the prospective validation cohort, but otherwise they were, and same for wound complications, but otherwise they were similar in many respects. And in terms of demographics, they were also similar in many respects as well. And so to briefly summarize what they found when they prospectively validated each of these 6 models against the prospective validation cohort is, I think perhaps unsurprisingly, they found that as the number of input features increased from 55 to 101 to 135, the predictive performance both stabilized and improved. And that was across both. That trend was found both in the generalized additive models as well as the random forest models. They found that the validation performance degraded for the generalized additive models for all different types of feature sets, but not for the random forest models. And in particular, and I'll go into this in a second in the subsequent slide, but they found that the overall best prospective validation performance was seen in the random forest model that had that largest subset of features, which was the 135 feature set. And so if you look at, and again, this is sort of I'll ask that you just look at this one corner of this large results table. And what this table shows is performance metrics for the 3 random forest models. So you have the 55 feature random forest model on the left, 101 in the middle, and then the best performing 135 feature set random forest model here all the way on the right. And what you'll find is that, yes, in many cases, there was a significant difference between the predictive performance in the original retrospective development cohort from 2014 to 2018 versus in the prospective validation cohort from 2018 to 2020. But in many cases, the predictive performance did not degrade. And so overall, this ended up, by both AUC and many other metrics as well, this ended up being the model that performed best of the 6 models that they prospectively validated.
Jayson, if I might just add something there. So yeah, the AUROX looks decent for prospective validation. Some of the other metrics really didn't, though. And as you might expect for some of the rare complications like 30-day mortality, where the incidence is only around 2%, the area under the precision recall curve was really poor. It probably ended up in the supplement. It was so poor. But F1 scores in precision for the rare complications was terrible. It was like 0.1. And so these models learned to make predominantly negative predictions for rare complications, and that's how they achieved high AUROC. But the caveat is that it missed a lot of actual deaths by making predominantly negative predictions. We don't see that as much with, we're moving away from random forest models and toward deep learning models. But that was, I think, a major weakness of this paper and of these models.
Yeah, and I think, prediction of very rare complications, I think, is a sort of a universal or a very, very common struggle for, especially for post-surgical complications like MI, PE, and those sorts of things that are catastrophic when they happen, but rare. And as a result of being rare, they're incredibly hard to predict. But perhaps most importantly, I think to this audience, and the people in this lab, is how the surgeons interacted with and used the tool, and what the study found with regards to use of the mobile application. So during the prospective validation period from 2018 to 2020, they had 67 surgeons at University of Florida enroll in the mobile application. And they had 193 cases where the surgeon first entered their assessment of the patient's risk of each complication before viewing the My Surgery Risk algorithm's output. And in 100 of those cases, they both gave their assessment of the patient's risk before viewing the My Surgery Risk output, and then once again after consulting the model, which enabled the authors to study how the model influenced the surgeon's perception of how at risk the patient was of various postoperative complications. And so interestingly, very interestingly, perhaps what they found is sort of there are three categories of, I think, interesting findings as it relates to this topic. First is, so let's just look at surgeons' assessment of risk before they looked at the My Surgery Risk output. And what you'll find is that there's considerable heterogeneity in how good surgeons are at predicting various postoperative complications. It's in some cases for things like, say, for example, like prolonged ICU stay, it was excellent. But in other cases, for things like deep venous thrombosis, it was not nearly as good. And in fact, there's quite a wide confidence interval, keeping in mind that they had just 100, a sample size of 100, but still, I think that the sort of the heterogeneity of surgeons' predictive power without consulting the model is quite interesting. So now let's compare the surgeon's assessment of postoperative risk to the model's predictions. And what you'll find is that, and this model being the 135 feature set random forest model, what you'll find is that in many cases it's quite similar, but in some cases the model does significantly better. So for example, in the DVT example, the surgeon's assessment of risk is not that good, but the model is actually able to predict that particular outcome with considerably higher predictive performance. And then the final point here that I think that's very interesting is looking at what surgeons think about this patient sitting in front of them before viewing the model's predictions, and then once again after viewing the model's predictions. And very interestingly, what they found was that in none of the cases, the model's predictions, in all of the cases, the model's predictions did not improve the surgeon's AUC, the surgeon's predictive performance in predicting what will happen to the patient after surgery, which I thought was very interesting. And I think that that might lend to some sort of discussion after we talk about this paper, after I finish wrapping up these slides, to sort of maybe hypothesize as to why that is and how that can be fixed for future models. So main takeaway points here are that automated data entry from EHR data eliminates the need for very tedious manual data entry, and it's right now, I think, a significant barrier to the use of many of these types of models by surgeons. And in the study, they were able to overcome that by putting a lot of effort into their sort of real-time analytics platform. They provided relative feature importance, the top 3 most important predictors of any given risk prediction, which may offer some explainability to the surgeon when they're consulting the model. And the versatility of the model in that it took it so they first sort of standardized model inputs into, sort of standardized it and used sort of a common data model allows the tool to be used in many different settings. And so some issues to consider, when thinking about this study are, so number one, the platform. So they use sort of a mobile platform. Is there, is there evidence to suggest that if you make it even easier for them to use it by integrating it into the EHR's interface itself, that'll make it more likely and easier for them to sort of consult the model's predictions before operating on any given patient. Another important point to consider is this point that was shown in table 4 about whether the surgeon's mind was changed or not before and after viewing the model's predictions. And a sort of interesting follow-up question to that is, okay, so the surgeon's risk assessment doesn't change, but how do you measure whether their behavior changed? Is there anything that they did differently as a result of consulting the model? Like, say, discontinuing nephrotoxics or doing something like that is not captured by their unchanged predictive performance. And then a number of other considerations that I think would be interesting to discuss, but I'm going to pass the mic over to Dr. Loftus to highlight any other points that he thinks are worth noting here.
Thank you. That was an excellent summary of this work, and I think your issues to consider are right on. Obviously, I'm biased towards integrating things into the electronic health record. I think the main limitation right now is that EHR embedded models tend not to be interoperable the way that something built on NISQIP would be, or something where you do a little bit of manual data entry. We'll try to get around that by using common data models, and that really only makes us interoperable with other institutions that have mapped their data to the same common data model. So we're using OMOP. Some people use Picornet. So that's, maybe a next 5-10 year kind of thing. In terms of changing surgeons' risk assessment and subsequent behavior, yeah, I agree. What we saw was almost nobody changed their mind or did any better. In one case, they did a little bit worse after seeing what the model thought. In terms of why that is, the lack of trust in machine learning models is sort of complex. I think one thing we haven't tried yet that we want to try is providing model certainty assessments. So not just what the model thinks, its prediction or its recommendation, but how confident is it that this is an accurate prediction. So that's historically been hard for us to do. We're working on using Monte Carlo dropout to make sort of a distribution of predictions by making permutations in which neurons are dropped with each pass, and then getting a distribution of predictions. And then we'll somehow convert that distribution to saying this is a nice tight distribution. We have relatively high certainty or confidence that whatever you're seeing is a reproducible model output and probably reliable. And if we see a very wide spread or high variance in those predictions, then we'll say any given one of these predictions could be an outlier, and you probably shouldn't even look twice at this model outputs. And maybe those certainty assessments possibly could build some trust, at least in saying, this is one of those reliable predictions, this is one of those outliers, I'm going to ignore it. Don't know if that works. That's just an idea, something we're going to try going forward. The optimal visualization of model outputs. So that's actually, we're hoping to start that in about 2 or 3 weeks. We made a usability survey to try to understand what would people like to see, what do they not like to see, and how can we make the app better. You showed the outputs, which is basically based on what some folks in the lab thought surgeons might want to see, and some of us are surgeons, but we haven't done any formal usability testing. That's next, and we hope to be able to improve the interface and actually show people what they want, or maybe make the interface personalizable, where you can choose what you see. There's some people maybe want to see their outcomes compared with their partners if they're in a big practice. Some people may not. We haven't done that testing yet. How data generated at the point of care should be captured. I think one thing this model doesn't use that I think a lot of better models and emerging literature use is waveform data. Waveform data for real-time predictive analytics is a little bit beyond our compute power right now. We're trying to get access to or more access to the NVIDIA supercomputer that's now housed at UF. And initially, we're going to use that for updating the model every minute, a deep learning model, updated every minute. Even that is much short of waveform data. But that'll be much closer to real point of care data than what we just looked at as sort of like Q1 hour updates, which is really not high enough frequency for anything other than the intraoperative data was every 1 minute, but otherwise, it's much less frequency of the data inputs in terms of actual point of care use. So I'm glad you raised those issues, and if anybody has questions about those, then I'd be happy to answer them.
I'll open it up to questions if anyone has any.
All right, well, I'll start. I'll start. So I really like this paper. I've been following what your group has been writing for a number of years. I think it's actually really important work. Early on, I have to admit, there were times when some of the earlier papers where I thought there was a little bit superficial. I remember when you guys published the my surgical risk visualization. But I honestly think that reading this paper, the technology and the thinking around this has clearly matured in a way that is really impressive. And so I absolutely congratulate you for that. Just starting to look at this as kind of a way to make kind of real-time informed decisions is, I think, really awesome. I have a billion questions, but I'll ask two. The first is outcome analysis. So really fundamental, and one of the areas that I have really struggled with understanding, and is so fundamental to this work and yet so difficult to do, is how do you effectively identify the outcomes? And there are folks that do NSQIP manual work. There are folks that pull information from the billing data, and there are then folks that are trying to identify it using a bunch of other metrics. And I wanted to know, one of the things that I found really difficult as an example is, how does one identify a wound infection in your data set? Because I've read all the papers and I'm still not clear as to how that's actually done. But it's amazing because I've reviewed probably a half dozen papers where people have tried to do that, and it's really hard to do. And so I wondered if you could speak a little bit to kind of that process, because it's really unclear to me as to how you guys are able to do that. And then I'll ask one other question, which I really, this uncertainty assessment you were talking about, I wondered if you might talk a little more about how that, because we just reviewed a paper, or just read a paper that was published in Nature Digital Medicine on the British creating that for the National Exploratory Laparotomy Audit. And that is a really interesting, they created something called RUNE to try to do uncertainty assessment. And I found it really difficult to understand exactly what the right use case is, right? Like, what's the right time that you could use that kind of uncertainty analysis. And I totally agree with what you're saying, that this is an incredible opportunity, especially with this interface that you developed to really kind of start to do that. And so I wanted to hear a little more about your thoughts just about how you can inject that into the process of thinking. So I guess 2 questions is outcome analysis and just where in the workflow and how does uncertainty fit into the way in which we would actually communicate with our physicians?
Yeah, great questions. Thank you for posing them. Your first question is kind of an easy answer and somewhat disheartening. So it depends on the outcomes. Some of the outcomes have kind of robust computational phenotypes. So acute kidney injury is one like that. We get pretty granular data on urine output, baseline creatinine levels, whether the patient has chronic kidney disease, whether they're on hemodialysis, and then creatinine trends over time. And we can pretty precisely timestamp the time when they develop different stages of acute kidney injury. And so that I think is a relatively robust outcome. And then there's some like mortality that, you know, we trust those, but many of those are based on ICD codes, and I don't really trust them probably any more than anybody else. So I am moving away from those outcomes, and in my own work only now is using predictions of prolonged ICU stay, which we have pretty precise date timestamps on. We can tell exactly who's been in ICU for 48 hours or more, and hospital mortality. And until we get more granular computational phenotypes. In this paper, I think in terms of outcomes, the greatest weakness is that sepsis also used ICD codes in this paper. So my apologies that it wasn't clear in the methods or in the supplement. We must have missed it in the supplement, or maybe somebody didn't want to admit that that was such a dubious method. But yeah, I think ICD codes for those outcomes are pretty unreliable. And so that one, we're working on our sepsis computational phenotype. And I think in wound infection, the other one you brought up, ICD codes. And so I tend not to use that. I'm not using that in any of my work going forward. That is offshoots of non-surgical risk, essentially, because I don't trust it probably any more than anyone does. To your second point about uncertainty estimation. So yeah, we have a ton of enthusiasm about that as well. And I agree with you that this may be a use case where uncertainty estimations might be have a viable application to decision making and building trust, and telling the user, is this one of those predictions that that you should pay attention to, or is this one that you should ignore? I think when we talk with folks who have pretty decent knowledge of machine learning models, they'll say, rightly so, that even some of the computer vision models are probably the best deep learning models that we have. They have the highest accuracy. But I think when that paper came out on Archive about the computer vision model failing to identify the elephant in the room, then it raises the question that this model might be 97% accurate, but what if this is one of those 3 out of 100 times when it is just dead wrong? Can it tell me that it's one of those 3 times? And then I'll ignore it. And can it tell me that it's one of the 97 times when it's almost certainly right on? And then I'll pay attention. So we don't know if that will work, but that's our intention. That will also take a lot of compute power, especially in real time. But I'm hoping actually to integrate that with the postoperative triage decision-making paradigm, that when we're making recommendations for this patient is pretty sick, high risk for mortality and prolonged ICU stay, they should go to an ICU, or pretty low risk and they can safely go to a hospital ward and they can probably go home in a day or 2, provided they continue to progress well after surgery. Can we accompany those recommendations with a confidence or certainty estimation and say, we're very confident in this recommendation, or actually, nope, this is probably one you should ignore. Maybe that will build trust. Maybe that will change the way folks make decisions. We can also make the EHR orders overridden when somebody's writing, ICU orders for a low-risk patient or floor orders for a high-risk patient. So some options there to actually improve usability, and there would still be overrides. There would have to be overrides. But to perhaps increase the probability that it actually affects patient care, which based on this paper, it looks like that would not have all affected decisions or any patient care.
Can I ask a follow-up to that?
Yeah, please do.
So you'd mentioned, I think, here and also in your previous answer, the idea of using these kinds of AI decision support tools as guidance for triage around whether a patient should be sent to the ICU or not, or whether or not a provider should perform a certain intervention or not. And my question relates to where the labels for these kinds of interventions, where you see these coming from. Since I imagine that the reason why we want to guide these decisions is because the way they're practiced in the moment, we see as imperfect one way or another. And if we replicate, if we, for instance, just try to use the existing data of who gets admitted to the ICU, we can never do better. We're just sort of replicating the patterns of how people are currently practicing. So I was curious, like, what sort of ways or what sort of vision you have for sort of pushing these sorts of practices beyond where we are now.
Yeah, those are very insightful questions. So in terms of where the classifications come from, so the classifications for over triage and under triage have to come from two things. It's a global risk assessment of the patient, which right now I'm just using risk for hospital mortality and risk for prolonged ICU stay, sort of as a composite. And then the other element we need is their actual triage disposition. Did they go to an ICU or did they go to hospital floor? And then in terms of where would you actually implement that, it would come from when orders are actually being written in electronic health record. There has to be, somebody has to sign in, they have to write admit to ICU or admit to floor. And that would be the decision-making point. In terms of, would we just be replicating what we've seen in retrospective data? So we do use the classifications come from retrospective analyses of, can we pick out those patients who are high risk, but they went to a floor, and the patients who are low risk and they went to an ICU, and how often does that occur? And you're right, we think it's actually sort of rare. Over triage of low risk patients to an ICU happened about 5% of the time, just at our hospital. It's the only hospital we know of right now. In our data, we're working on external validation. But under triage of the high-risk patients to hospital wards was about 12% of all the ward admissions. And that's probably a greater sin, because that's the time when you're not just spending too much money, you could actually hurt somebody because they could get sick and nobody's going to be checking on them. And that's the patient who might do okay, but they might crash and burn, have a horrible complication, and we're slow in rescuing them, and sometimes unable to rescue them. And so that's where those classifications come from. And so going forward, then we would just say, can we run those same predictions and pick out those high and low risk patients, check what the order was written for, and then say, this looks like over triage, and warn the order writer, say, hey, this looks like you're sending a low risk patient to the ICU. Unless you have a good reason to override it, you need to send them to a floor. And vice versa. This looks very much like a high risk patient that you're trying to send to a floor. We'd recommend ICU admission unless you know something we don't, like they're DNR, DNI, they just want to go home palliative, and then you override it based on some criteria like that. Or just disagree with the model, which could be based on an uncertainty estimation that the model is highly uncertain of its prediction. You say, well, I'm going to go with my gut on this one, which is usually right anyways, as we saw in the paper.
I see, thank you.
All right, well, I do want to be respectful of Dr. Loftus's time. I don't know if Dr. Brat, did you have one last question? Or
I have a billion questions, but I will say thank you so much for taking the time to describe your experience. It's an amazing one. You guys have done such a impressive job kind of moving this space forward. I would love to talk further about, you were talking about this issue of surgeon resistance. It'd be really interesting in a future time to even discuss, how are the things that we're doing actually helping to overcome some of that. But I agree, we should respect your time tonight, and thank you for taking the time to be part of this. And I hope when you publish your next great paper that you'll be willing to come back and talk with us again. So thank you so much. I appreciate it.
thank you, Dr. Loftus.
Yeah, thank you so much for those kind words and for the invitation to be here and meet you all. I'm a big fan of the work that this lab does. I think it's wonderful that you have folks integrated from all different levels of training, all different disciplines, all getting together and talking about these issues holistically, which understanding them that way is probably how we move forward. So, so it's been wonderful meeting you all. Thank you so much for having me.
Have a good night. Thanks so much.